Hi, my name is Jeff Verhagen. I'm the clinical director here at Freedom Physical Therapy Services in Brookfield, and I'm going to be talking to you a little bit about the temporomandibular joint today. It is TMJ Awareness Month, so we thought we'd share with you a little bit of information to kind of tease you a little bit on how we as therapists go ahead and evaluate and treat TMD problems. TMD stands for temporomandibular dysfunction. We all have TMJs, which are the temporomandibular joints. Before we get started, I want to do a shout out to all the veterans on Veterans Day. Happy Veterans Day, and thank you for your service. So one of the things I want to try to accomplish today is just kind of summarizing a PowerPoint presentation that I do to that I give to dental offices throughout the greater Milwaukee area, and we'll try to hit some of the highlights and kind of tease you a little bit with how we go about evaluating and understanding TMD issues. Unfortunately, there was a study done that showed that the actual diagnosis of a temporomandibular dysfunction takes about 4 years. In many cases, unfortunately, patients may have ear congestion, headaches, facial pain. They see their dentist for a tooth problem. The teeth are fine. They see an ENT. The ears are fine. They see a neurologist. They have a MRI. There's nothing going on there, and they end up suffering for about 4 years. We often pick up on TMD issues because our patients that come in with neck problems, we screen for TMD problems, and that's one of the ways that we are able to help that population, as well as getting out to the dentists in the community and educating them on what it is that we do, and it's been well received, and we receive several referrals a week, and I probably treat maybe 3-4 patients a day with this population. One of the first slides that I show the dentist is a slide that shows a 50-50 relationship between the face or facial muscles in the jaw and the neck and the jaw. So in order to effectively treat the jaw, you also have to be able to do a very good assessment of the upper back, neck, as well as the jaw and the facial muscles of the jaw. So that's really, really important. You can't treat one necessarily without the other. TMD is primarily a condition of young adults, and more common in women than men, unfortunately, as much as 50% more. The one thing that we have had patients here that will come in complaining of joint noises and maybe clicking, and I want to make it clear to the public that if you have joint noises and you're functional and pain-free, those aren't typically patients that we'll see. We might give you some educational pieces, but we're looking for patients that truly have a TMD dysfunction. As a follow-up to that, only about 7% of the population who actually have a benign clicking end up having painful clicking over about a 7.5 year to 10-year process. So it really, fortunately, is not something that you have to worry about if you have clicking or popping or joint noises and you are pain-free. Key message is joint sounds and noises are common, and we want to avoid over-treatment, especially in the absence of pain. Just wanted to touch on some of the symptoms of TMJ, which again, may get overlooked, and maybe one of the reasons why patients struggle with getting a diagnosis and getting to a TMJ therapist that can give them the appropriate help. Headaches and neck and throat pain are very common. Pain behind the eyes, unexplained toothaches. I actually just got done treating a patient who was complaining of toothaches, and in doing my muscles of mastication palpation exam and palpating her masseter muscle, which is on the side here, she actually said, that is recreating my tooth pain. So again, one of the reasons why sometimes you go to a dentist, the dentist says your teeth are fine, but you can have referred pain from trigger points within muscles that can get you a little confused. Earaches and congestion in the ears and ear ringing is very common. Oftentimes these patients come in after seeing an ENT, and the ENT says there's nothing wrong with their ears, but you do also have a muscle underneath here called the medial pterygoid that very often refers pain to the ear, can give it a sense of fullness and congestion. And I always tell my patients that this area right here is kind of like a hamburger. The top of the bun is this muscle here is called the masseter muscle. The actual jawbone is the hamburger, and the underside is the medial pterygoid, and that's the bottom of the bun. Those muscles are responsible for closing the jaw. And if you're a clencher or a grinder at night, they can overwork, and they can develop trigger points that can actually refer pain to the teeth or the ear, and basically trick you into thinking that you have a different problem. Dizziness is another one that can be related to TMD, so I definitely, if somebody comes in with dizziness, want to tease out to make sure it's not a TMD problem. We do want to check on the popping and clicking of the jaw. You see that I have a bilateral stethoscope. I put this on and I actually get in and listen to both sides of the jaw. The noise is very important when it happens. So as the person opens their mouth, where the noise occurs tells us an awful lot, as well as when it closes, and I won't get into details, but it's certainly something that we look at, very important. Obviously, if you have pain with chewing or talking, that's another classic sign of problems. Facial pain, I would say difficulty closing your teeth is another issue, and just in general, tired jaws, okay? The other issue that will come up also is patients will have difficulty with limited opening or locking. And most of the time when that happens, they've been an active clicker or popper, and all of a sudden the noise stops. And when the noise stops, that's usually a disc that displaces and it doesn't relocate. So when the patient goes to open their mouth, they run into a block on one side. The other side, if there isn't a problem with the joint on that side, it will continue to move, and your jaw will actually deflect to the left. The definition of deflection is when you open your mouth and the jaw moves to the left, okay? Deviation is the jaw may move that direction, but it always moves back to midline, all right? So if a joint, if a disc is displaced, and then relocates, very often what you'll see is the jaw moving to the one side, the joint reduces and comes back to the middle. And that's how, again, we tease out a muscle problem versus a disc problem. Muscles will pull you to one direction. Discs, if they relocate, will click and you'll actually deviate back to the midline. Many of the causes of TMD can be poor posture, whiplash within a car accident. Basically, your teeth and your bite can be a problem. If you're a grinder or a clencher at night, that can be a big issue. Dental issues, unfortunately, can be an issue. I mean, you put in a filling that maybe has a little bump on it, that can throw you off. I had a patient who had a crown that actually started to rock, and unfortunately that set off a whole series of events, and she could leave feeling great, but within 2 or 3 days her symptoms came back. So the answer to that was getting her back to her dentist to basically get the crown refit and reset so that it didn't move around. Parafunctional habits, chewing on your lips, excessive chewing of gum or candy, chewing on your fingernails. I had a young girl who came in with her mother who had a lot of joint noise, but she was pain-free and functional. I pretty much sent that patient home because she did not have pain, but one of the things I noticed in the assessment was that she was biting her nails, and I asked her, I pointed it out to her, asked her to try not to do it, and through the whole evaluation, maybe she was a little nervous, but she probably did it 4 or 5 more times. I mentioned to the mom there's actually some fingernail polish that she could use, that if she were to bite her nails, it tastes terrible, and it kind of works to break you of that habit. I want to just follow up with poor posture a little bit and why that becomes important. If you're listening at home, we want the teeth to come together. And when you have your head in a poor posture, when you bite down, the actual bite changes from this flex position to a neutral position to when you're backward bent. So very often, if you do have postural dysfunctions, that can change your bite in your jaw, and really one of the reasons why we emphasize posture so much in the upper back and neck. I recently had a crown put in, and my dentist was doing the tap test while I was laying down in the chair, and I mentioned to him, I said, Doc, I don't chew my food lying down, I chew it sitting up. And he goes, oh, yeah, okay, let's do the tap test sitting up then, which changed my posture. So ultimately, the position that you're in will often make a difference in your posture with your bite in your jaw. We get concerned about hypermobility with jaw problems. That can lead to some issues within the actual joint itself. We use what's called a Beighton scale. It's a 9-point scale in an effort to pick up hypermobility. I won't get in great detail, but what we tend to find is hyperextension in the knees. The knees snap back, the elbows snap. So that would be, knees would be 1, 2, elbows 3, 4. Bending the finger back is on each side 5, all the way to the forearm would be 5, 6. Bending the finger back beyond 90 degrees, 7, 8. And then being able to stand up, forward bend, and palm the ground is 9. So if you're anywhere in the upper echelons of close to 9 out of 9, we get concerned that you're hypermobile, and we have that conversation with your dentist and your doctor. In general, I would say that those of us that are in the TMJ or TMD treatment world, we base everything we do off of a 1992 gold standard study that kind of distinguishes and helps to come up with a diagnosis of whether or not you have a joint problem, a disc problem, or a muscle problem, or a combination of the three. This was a study that was updated in 2014, but it really is the premise for what we do as TMJ therapists in an effort to come up with an accurate diagnosis to best treat our patients. During our evaluation, our PT evaluation, of course, we look at posture, we look at facial asymmetries, we look at cervical and thoracic range of motion, and we look at TMJ range of motion. And as we're looking at it, we listen and we measure. We look at mouth opening. We look at protrusion, which is when you jut your jaw forward. We look at lateral deviation both directions. And then we look at overjet and overbite. Overjet is how far forward your front teeth are away from your bottom teeth when your teeth are together, and overbite is how far do your top molars cover your bottom molars. And these are important findings, because if you have a big overbite and let's say your teeth cover 4 to 5 millimeters, and we measure open up to 34 millimeters, you're actually probably opening up 39 millimeters because of the overbite. We look at palpation of the actual joint and the synovials that are located in that area. All of the muscles of mastication, which I won't necessarily get into, but we do an external exam and palpating everything. As I mentioned, I found a patient earlier today that when I palpated her masseter, it recreated her tooth pain. And then we do an intraoral exam where we look at all the muscles inside the mouth, as well as assess the joint play of how well that joint opens up. We look at passive intervertebral movements of the upper back and neck, and of course the strength of the muscles in the neck and the upper back. And that's a big problem that we see, especially with poor posture. You have weakness between your shoulder blades, which leads you to forward postures, and simply does change the mechanics of how your jaw actually works. I'm going to do a little side story here. My daughter had all 4 of her wisdom teeth out, and one of my concerns was that it was a young surgeon, and one of the things that was emphasized up at the University of Minnesota's little TMJ residency program that I went through is that you don't want that mouth open for more than about 2 or 3 minutes if possible. So I suspect that her mouth was propped open, and they pulled all 4 of the wisdom teeth out, and unfortunately she ended up having an issue where she couldn't close her mouth, she couldn't open her mouth, and she had a crossbite. So she was quite messed up. The good news is it was mainly muscle. So as I got in and did some dry needling with her and some soft tissue work with the muscles and some neuromuscular reeducation to get the jaw to open straight, within probably about 3 to 5 days, she had normal opening, normal closing, and no more crossbite. So the moral to the story is small problem, small fix. If you let it go, it becomes a big problem and a harder problem to resolve. So that's why we try to get out to do these talks and educating the dental world and the general public, so that if you have any of these sort of issues, you can hopefully get in and get some help sooner than later. So as I mentioned before, the 3 main categories of TMD based on that 1992 study is essentially masticatory or muscle disorders, arthralgia or joint issues, and disc derangement disorders. One of the ways that we tend to tease out the 3, particularly the joint, is we use a little piece of felt and we put it in the back of the molar and have the patient bite down on and ask them where they have their pain. So if they put this in the left side and they bite down and they have pain on the left side, that's indicative of typically muscle pain because we've separated the joint. If they bite down on this side and have pain on this side, which is the side that compresses, the joint actually compresses, that leads us to probably believe that there is potentially more of a joint problem, and that's going to be confirmed with your palpatory exam. I had a patient who came in, and on the very first visit he said, I'm about 80% better. I was really having a lot of problem, and I said, well, what was it that made you feel better? And he said, well, I have a son who's a physical therapist, and he said, Dad, are you chewing just on one side? You need to be chewing on both sides in order to help your cause. And really what was happening is he was having pain on his left side, so he tended to want to chew on his right side. Well, based on what you just learned from the bite test, if you're chewing your food over here, you're causing actually more of a compression of the joint over here. So his son's advice was, Dad, chew on the side of pain, and preferably on both sides. And probably within a week, he said 80% of his pain was gone by the time he got to see me. So I know it's a little odd that you would want to necessarily bite down or chew on the side of pain, but in his case, since his joint was irritated on that side, that was extremely effective for him. When we're dealing with a disc displacement, we kind of categorize those into 3 stages. We have disc displacement with reduction, and that's typically if you have a disc that's displaced, usually you'll hear the click right away in opening, and it will not restrict your opening because it goes right back into place. And in fact, I can show you here on my little diagram here. This is the teeth in the front, and we have an actual jaw. This is the mandibular condyle, and there's a little fossa, the maxillary fossa, of which the disc sits in between. And mouth opening, the first part of mouth opening is considered rotation, and the second part of mouth opening is translation. And when you open, that disc is supposed to stay right in between. So if you have a disc displacement, the disc is out in front, and when you go to open, it clicks back and does not restrict your opening. Stage 2 is a disc displacement without reduction with limited opening. So the disc is displaced, you go to open and it doesn't doesn't reduce back, and it's actually in the way, so you have limited opening. And if it's on both sides, you have limited opening on both sides. If it's on one side, that's where very often you'll have the jaw deflect to the one side. Especially if it doesn't reduce, you go to, if this is the left side, you go to open and your jaw will move to the left because this is in the way and it's not on the right. If it were to reduce, you go to open and it would reduce, you would see the jaw going to the left, and then it would pop back to the middle because the disc reduced. And the same thing when you close, it would tend to come straight and then deviate because of the disc popping back. Okay? I know one of the questions I asked Dr. Schiffman, who runs the TMJ residency program up in Minnesota, University of Minnesota, is I asked him, I said, if this disc displaces, and the goal is basically not to worry about getting that back into position, but basically pushing it out of the way, is there any concern about degenerative changes or problems within the joint? And he said, basically, as long as you're not predisposed to serious osteoarthritis or rheumatoid arthritis, not a problem. And in fact, the tissues, we call them the retrodiscal tissues, or the posterior ligament, actually morphs itself into a new disc. So the body is good at that. It actually ends up creating a new disc. And our goal, if you have limited opening, is really at this point to move the disc out of the way. The oral surgeon up there that gave his lectures talked about multiple surgeries and trying to get that disc to reduce and stay in position. And the bottom line was the research is now telling us it's very difficult to get it back. We don't worry about it. In many cases, we a year later, it's displaced anyway, and it's out of the way, and that's why the patient is actually able to open their mouth comfortably. Okay? The stage 3 is a disc displacement without reduction. So it's displaced, it doesn't reduce, and basically it's out of the way, and you can open as wide as you want, and it's not a problem. So again, that's why deviation and deflection are important terms to understand, and when the click comes in the motion and when it comes in the closing are all things that a therapist and your therapist, if you're working with anybody, will be looking at in order to get an accurate assessment and diagnosis of how to help you. That is really the key to being able to accurately treat you. We're not just randomly treating you. It's based off this 1992 and follow-up study in 2014. Our goal essentially with temporomandibular dysfunctions is obviously to decrease your pain and decrease adverse loading, and that may be teaching you to have the tongue on the roof of your mouth. If you look at me closely, when I keep my tongue on the roof of my mouth, my jaw naturally drops. Of course, splinting and getting to the appropriate TMD specialist, dental specialist. There's all sorts of different sorts of devices that can be used to try to protect adverse loading. Sometimes it's at night, sometimes it's 24/7. And there's plenty of great TMD dentists out there that can advise you as to what the most appropriate device is for you. We work very closely with dentists and these TMD specialists, as well as your primary doctor, in an effort to be able to get you an optimal outcome. We want to obviously restore your function. That's what I said before, pain-free and functional. And resume your normal activities. Conservative therapy for TMD issues includes physical therapy, patient education. I think there was a study by Dr. Shipman who basically found that if patients used the placebo group and all they did was do exactly what the self-help handout that he gave out, and he found, I think it was 30% of those people got better on their own simply by listening to the advice of the self-help document that he hands out. Certainly medication sometimes is necessary. I mean, if you have a hot joint and you can't get it to settle down, an oral or a non-steroidal anti-inflammatory or other physical therapy modalities that we have can help with that. And as I mentioned before, orthopedic appliances. The good news is long-term follow-up on these patients is that they're pretty stable. Somewhere between 50 and 90% of these people, once they have an optimal outcome with conservative therapy, 5-10-year studies show that they're very stable and have no problems. So we as therapists like to think that we've done our job, that the dentists have done their job, the TMD specialists have done their job, and we get a patient to a comfortable level. I could get into a little bit of the PT treatment that we do, but I think that's going to get just a little too technical for this talk. I think hopefully what you've learned here today is just kind of generally a little bit about how we assess, how we categorize, and how we can help this population so that they don't end up being that person who 4 years later comes in and says, I've been having trouble for about 4 years. So I think that's it for now. I'm going to sign out, and if you have any future questions, you can probably refer to our Facebook, and the questions can hopefully get to any of our TMD specialists that we have at all of our sites at Freedom. So thank you.